Good afternoon, everybody, and we're absolutely delighted to be here today, and we hope that you find our double act will be helpful to you, and also we hope will be thought-provoking. One of my other roles in respect of ADAS nationally is that from day one after the Panorama programme on Winterbourne View 2 years ago, I've been the ADAS lead in response to Winterbourne View. And I'm now going to hand over to Viv.
Hi, Andrea and I are going to do a double act, and we're going to swap, but hopefully not too much. And both of us believe passionately in this subject, so we're going to try and keep to time so that there'll be time for questions and discussions at the end. As you've heard, my name is Viv Cooper. I'm Chief Executive of a charity called the Challenging Behaviour Foundation, which focuses specifically on individuals with very complex needs, severe learning disabilities and behaviour described as challenging. We're a small but national charity. We're not a support provider in the sort of traditional sort of sense, but we provide information and support to families around information and training. And we also try to influence strategically nationally to press for change for this particular group of individuals. So I'm going to talk about my own experience as the mum of a young man with severe learning disabilities and behaviour described as challenging, and also the experiences of the families that contact us. And I'd just like to say I think it's really important that Andrea and I come from very different backgrounds and from very different parts of the system. But we both believe passionately in getting it right for this group of individuals, and we work very closely together. We're on a number of different boards and groups together because we really believe that we need to make a difference for this group of individuals. So I'm going to start, if I can find the gadget, start by being clear about who we're talking about. And often people have lots of labels and we group people together. So I think it's really, really important to remember that we're talking about individuals, real people, real lives. And this is a picture of my 3 children. And my aspirations for all 3 of them are the same. And that is that they lead interesting, happy and fulfilled lives. And the only difference between Daniel and his sisters is that because of his complex needs, he needs more support than his sisters to enable that to be a reality for him. But that shouldn't be a problem because we know a great deal about how to support people well. And so we should just be able to do it. And the quote next to it is from the best practice guidance written by the late Jim Mansell, which reminds us that people who have these complex needs and these quite frightening sometimes labels have the same human rights as we all do. And they also have the same needs as we all do. So Daniel has the same emotional needs as his sisters, and we often forget that because we're so focused on the difficulties that his behaviour presents. It's also important to remember what it is that we're trying to do. What is it that we're setting out to do when we're thinking about Daniel? And we need to remember all the time that what we want to deliver is good outcomes for the individual. So we can have all the systems and processes in place that we like, but actually the test of whether it's working is whether Daniel has a good life. And we need to do that through a person-centred approach to planning and delivering support and services, which are local, high quality and flexible. And that's what the policy says. That's what personalisation is about. And what we're going to be talking about in this session is to say that actually for this group of individuals with the most complex needs, personalisation is the only way to support people well. So we know what we want to achieve, but we also know what doesn't work. And as Andrea says, 2 years ago, we were all shocked to see the scenes that we saw on the television Panorama programme of what was happening at Winterbourne View. And just in terms of personalisation and getting it right for people, there's a quote here from a family carer who says, I know how I would feel if suddenly I was taken away from all that was familiar to me and had to live with people I didn't know who were in crisis and behaving in ways which were challenging. And I think it's important to remind ourselves that what would it feel like for us, and then try to imagine what it might feel like if you're not able to tell people how you're feeling or to access people who can support you. And that was a situation that people who were in Winterbourne View were in. And the quote at the bottom is taken from Margaret Flynn's serious case review, when she says it was so traumatic when he was taken away to Winterbourne View, and then it just got worse, absolutely horrendous, and I can't yet see the light at the end of the tunnel. So this is the absolute opposite of personalisation. So looking back, thinking about my experiences with my son Daniel, there were sort of two pathway options. So option R was where you look at the individual and you make an assessment to see whether which services will be appropriate to meet their needs, and then you try and fit those individuals into those existing services. Commonly that doesn't work, and it results in exclusion from local provision or service breakdown. And then the response to that is to look for an out-of-area place that will take the person, and then monitor and review that placement. And certainly that was my experience with my son Daniel. He left home at the age of 9 to go to an out-of-area 52-week residential school. He was there for 10 years, and in those 10 years he had a number of reviews, but it was really just to say, well, actually, is the placement still okay? An alternative would be option P, which was a person-centred needs assessment with input from a range of sources, where everyone jointly agrees the outcomes, and then the local support and service provision is designed around the person, and then that's monitored and reviewed with the circle of support around the person. That's what policy says should happen. That's personalisation, but unfortunately that's probably less likely to happen. So the question that we're asking you is which pathway is more likely, and the reason they're called option R is the reactive pathway where you're reacting to someone's needs, and P is a proactive pathway where you're proactively thinking about meeting the needs of individuals within your locality.
Going to talk a little bit about Winterbourne View, because it is very much a case in point about the needs of people who are really complex, and how appropriate and possible a personalised, person-centred approach is. Some of the key findings from Winterbourne View, and there were a great deal which have been set out in the serious case review, in Transforming Care, the DH report, and the Concordat. And it says that too many people are placed in inpatient services for treatment and assessment and are staying there for too long, and it is neither treatment nor assessment. This model of care goes against government policy and has no place in the 21st century. People should have access to the support and services they need locally, near to family, near to support networks, so that they can live fulfilling lives within the community. Personalisation. Winterbourne View was an extreme example of abuse. But following Winterbourne View, there was a whole raft of inspections, investigations, audits and reviews right across 3,300 people in treatment and assessment units and similar establishments in England. We found evidence of poor quality of care, poor care planning, which also means poor commissioning, lack of meaningful activities to do in the day, and too much reliance on restraint. All parts of the system, those who commission care, those who provide care, and individual staff, the regulators and government, have a duty to drive up these standards. And there should be zero tolerance of abuse, something to which I think we would all sign up to. And yet, 2 years on, those shifts, that move, those changes have not yet been embedded. The other important aspect that we discovered about this, and it links entirely to the issue of personalisation and people with more complex and challenging needs, is that this is a whole life issue. One of the saddest quotes I heard in the last 2 years in my involvement in this work was a very senior clinician standing up and saying, we export them really young. And as Viv has already told you, her son's story started with a residential school, which then led on to very closed institutional forms of care as a young adult. The other thing that was really clear in all the findings from Winterbourne View and the other inspections and investigations is that personalisation and person-centred approaches were largely absent. There were a number of key recommendations that came out about only local action can guarantee good practice, stop that abuse and transform local services. And that's local action both in terms of developing specifications and models of service and commissioning that. And Viv mentioned in her last slide about monitoring and review, and one of the saddest aspects of these people with the most complex needs who are most vulnerable is the low level of monitoring and review that was taking place. People became invisible within the system. The other powerful piece of learning this is that people with learning disabilities and their family carers need to be listened to. We're talking about co-production here on a much larger scale than we have now. And working with them to develop person-centred, personalised approaches across commissioning and care. Build understanding of the reasonable adjustments. We talk about reasonable adjustments, but the number of practitioners who did not understand what that meant, or those reasonable adjustments were not being made, was stunning. To commission the right model of care to focus on the needs of individual people, looking to avoid the factors which might distress people and make behaviours more challenging, building positive relations in current care settings. And focus on early detention and prevention and crisis support, and ensure that we work together to plan carefully and commission services for the care of children and young people as well as adults. Personalisation for people with complex needs works, and we need to change the way that we commission and develop service models, but we also need to change attitudes and approaches to make this happen. The evidence is there in the examples of people's lives, and over the last 2 years those examples have been many. Personalisation for people with complex needs is difficult. I wouldn't say it was cheap, but it's nowhere near as expensive as some of the placements that are being paid for now in treatment and assessment units. There's a big challenge in whether the money follows the people when we change those models of care, and that's being debated at the moment. The Minister of Care, Norman Lamb, has just recently said, who is backing this whole issue about personalisation and person-centred approaches for people with the most complex needs in our communities, and in particular is holding all of us to account in terms of the progress and improvement since Winterbourne View. And he has recently been quoted very publicly as saying is that there will be no hiding place for commissioners who do not take this on board and make those changes.
So we know what doesn't work, and we also know what does work. So my son Daniel could easily have ended up in somewhere like Winterbourne View, but actually he lives in his own 2-bedroom bungalow, about 10 minutes walk from my house. He has tenancy rights within that accommodation. We've designed, it looks like an ordinary house, but it isn't. We've put a huge amount of effort into thinking about how the internal arrangements within the bungalow and externally are designed. We've done that by working in partnerships. So Daniel has a circle of support that includes his family, that includes the staff who support him, that includes an advocate, includes a whole range of people. He's supported by staff with expertise, knowledge and skill, who understand about behaviour, who are able to communicate with him. Daniel has no verbal communication and a range of behaviours described as challenging, some of which are life-threatening. It's been achieved through good management and planning, And it's been absolutely focused on outcomes for Daniel. So how will we know what works for Daniel? And how we know is that he leads that interesting and fulfilled life that I spoke about at the beginning. So we can make it happen, but as Andrea says, I don't think we should underestimate the challenges that can present. But when we get it right, it makes a huge difference. So there's a quote again here from Jim Mansell, which is, "A successful service looks like an ordinary home or occupation when in fact it's a carefully designed and organised service dependent on a great deal of skill and management." So although it looks ordinary, it isn't. And I think we need to be wary as well of when we get it right, that we don't dismantle that, because evidence that it's working is not evidence that it's not needed.
Thank you. Our job is to find ways of making personalisation work for people with the most complex needs, not to continue to find reasons for it not to. There are a number of key challenges which are up on the screen at the moment, but there also are major opportunities. These are the ingredients for success. But what is fundamental to this is the co-production with people who have a living experience of health and social care in these situations. What you have up on the screen at the moment are a number of key questions. So what is it that you could do to move this agenda forward? What are your responsibilities? How can you influence? And what we've tried to come up with is some straightforward and simple ways of doing that. So who needs to be influenced? Who do you need to ask these questions of? Health and wellbeing boards, learning disability partnership boards where they still exist, and where they don't, ask why they don't. Safeguarding boards and Health Watch, of course. And what are the sort of questions that you can ask? Is there a local understanding of the key issues? What is happening locally to people with most complex needs, and particularly those who are in treatment and assessment units and similar placements? Is there a local joint improvement plan? Because there should be. And what does it say? What detail does it have? What does it tell you about those people? Are there robust joint commissioning plans and arrangements in place, not just for the mainstream, if you like, learning disability or other types of service, but for those most complex areas as well? Do we actually know what placements have been made, by whom and where they are? It seems ridiculous to think that we should ask such a question, but 2 years on from Winterbourne View, we are still trying to track down who are managing some 500 cases. Are people regularly reviewed and visited? Are people visible? Are they in our line of sight? Are they being cared for by us as well as by the providers? Are we monitoring and responding to individual and collective issues and concerns? And are we aware of emerging trends? That's particularly important for safeguarding boards. And how involved are we with people with a learning disability and family carers, or generally with people with more complex needs? Is co-production a reality in your local area? And how do we assess and monitor and review and account for the quality of services? Some of the other major issues which have emerged from what's happened since Winterbourne View is there are still ongoing and outstanding issues which are really significant around restraint, medication and the use of the Mental Health Act. And they are questions that we need to all be asking, both as local citizens but also as professionals and practitioners. So what are the next steps? Well, the next steps are underway. In terms of leadership and direction, an improvement programme was agreed by the Department of Health and the Secretary of State and the Minister for Care Services. That came out of the Concordat document which was published last year and the DH report Transforming Lives. That holds together all of the key improvements which need to take place, and the improvement priorities were identified. And as a result of that, money and an improvement programme was allocated, and a Winterbourne View improvement team and board was set up. And the leadership from that comes from the Local Government Association and NHS England. And Chris Bull is the chair of the Winterbourne View improvement team. Viv and I are both members of the improvement board, and I guess we see ourselves not only as continuing to contribute to the improvements, but I think part of our job is to nag and activate and campaign for those improvements to be embedded and implemented. So what's the accountability for these improvements and this whole issue about personalisation in these complex situations? Well, the Minister for Care Services, Norman Lamb, personally chairs the National Programme Board for Learning Disability, and through that programme board holds all of us to account for what progress has been made. As I said, the improvement team, there is a board where we do challenge as well as support. Local learning disability partnership boards, health and wellbeing boards and adult safeguarding boards all play a role in local accountability for this as well.
So thinking about what you can check in terms of your own progress, there's some things here that we've listed. You can check that your Winterbourne registers are accurate and that they include children and adults, because as Andrea said, this is a lifelong issue. We often get it wrong in childhood, and so we need to make sure that any improvement programme includes children. You need to check that reviews are being carried out that involve the person and their family. You need to be clear that there's evidence of the support that's provided to deliver good outcomes for the person. You need to check that the review information that you collect from all the reviews drives local support and service development. And you need to check and constantly reinforce the commitment, leadership, and actually the resource for the change management. And finally, I just want to leave you with a quote from a family carer about quality monitoring. And there's a whole load of systems and processes around quality monitoring and outcome measurement. But a parent summed it up really simply, and it's this. And although it was directed at support providers, it could equally be commissioners or healthcare professionals or any number of us. And it's this: I want support providers to ask themselves, would you like to live your life like this? Would this be good enough for you, for your son, daughter or relative? If the answer is no, you need to change what you're doing.
As promised, we've got about 5 minutes for questions, so we've got a roving microphone, so who'd like to go first? At the back, which is handy. And could you introduce yourself before your question? Thanks.
My name is Elena Collier. I work with people with learning disabilities and complex
We're having trouble
issues.
hearing you. Could you put the mic a bit nearer? That's better.
Hi. Can you hear me now?
No,
Yeah?
I can't.
My name is Elena Collier. I work with people with complex needs. I would like to address a question to Viv. If it was today, do you think you would achieve the kind of support your son has had?
If it was today. So, did everyone hear the question? It was if it was today, do I think I would achieve the support that my son has? Yes, I hope it would be. I don't want to underestimate how difficult it is, and that it's constant. So it's we constantly review what we're doing and how we're doing it. It's increasingly challenging. But we know what is the alternative. So the alternative for Daniel, at the moment, he lives in the community in his own bungalow. He has a good life. A similar cost was if he got to crisis would be that he would go to somewhere like Winterbourne View, to an assessment treatment centre, which would cost more. So we have to make it work. We have to. There is no from a family carer perspective, there's no alternative. I have to make it work for him. What I would say is it shouldn't be that difficult. It shouldn't be that difficult because actually it would be easier for him to go to an assessment treatment unit, and we have to make it easier for families. That's what the Challenging Behaviour Foundation is constantly trying to do. That's what ADAS is trying to constantly do, to actually think we've got to make it easier to do the right thing and less easy to do the wrong thing.
Thanks. Should we take another question rather than Andrea come back on that? Who'd like to ask another question? Andrea, do you want to have a go at answering that one? Because from a director's point, do you want to go to answering that question from a director's point of view? You know, could you do it now?
Okay. First of all, before I answer this, I will answer this as a director of social services, but of course the majority of these placements are NHS placements, and one of the key challenges for us as directors of social care is ensuring that in the future, from now on onwards, is done in a much more joined up way, and Norman Lamb is calling for more pool budget arrangements in this situation, so we pool all of our resources. It's not getting any easier. I mean, everybody knows that in terms of the funding of the sort of care that Vivien has described for Daniel. But she's absolutely right to say that actually it is cheaper than, say, £4,000 a week that would be paid in an institution like Winterbourne View, and that they're not, Castlebeck are not the only providers who are charging that amount of money. The challenge for us, for me as a director, is understanding what is out there as an alternative, because it isn't like switching a light off and switching another one on. You know, there is this huge progression from where people are to where we know they need to be, and that requires us to get lots of other partners involved. So in terms of housing, private developers, other private providers or independent providers who may be investing in a different physical environment of a high quality. And as I said, those things don't happen overnight, and it is challenging us as well as it is challenging our health commissioners to thinking about what those models of care are. One of the pieces of work that's come out of the work so far over the last 2 years has been in developing joint health and social care commissioning service specification, a model of service that sets the highest standards and the specification for what personalisation, person-centred support would look like for people with the most complex needs. What we need to do is find ways to embed those standards and those thinking into a joint commissioning approach, and I think that is our greatest challenge. The money right across local government is a big issue. And so it isn't that we will stop funding complex packages of care, because if anything, they are in some cases more protected than other elements of care and support. But the challenge is in terms of the transition from where people are now and continuing to fund that whilst we develop something else. And again, that's a challenge that we have to face and meet with our health colleagues.
Thanks. I think we'll wind it up then. Slides for the presentation, as I said before, will be a link will be emailed to you. But can I ask you to thank our two speakers one more time? Thanks very much.
You're welcome.
For those who are staying, the next session follows immediately, which is legal risks and challenges in health procurement.